Welcome back to Mastering MHA MBA. In our last session, we established the scale of healthcare spending. Today, in part 2, we are shifting from the what to the why for MHA and MBA students. Understanding the mechanics of cost is essential. We'll examine how technological advancement, administrative overhead, and demographic shifts push expenditures higher. Let's break down the drivers. Section 4, Spending by Category. Where the money goes, personal healthcare consumed 84% of overall spending in 2020. This includes hospital care, physician services, prescription drugs, nursing home care, and home health. The remaining 16% covers program administration, both public and private, government public health spending, and investment in research and structures. Hospital care dominates. Hospital care is the largest spending category at nearly one-third of the total. In 2020, that meant over $1.3 trillion. Hospital costs grew at 8% annually from 2000 to 2005, raising concerns about acceleration. Growth moderated to 6% in the second half of that decade. Patients pay approximately 3% of hospital care out of pocket. The rest comes from insurance. Physician and drug spending. Physician services accounted for 20% of total spending in 2020, but that understates their importance. Physicians admit patients, recommend surgeries, prescribe drugs, and oversee the entire delivery system. They indirectly control most healthcare spending. Prescription drugs took 8.9% of spending. Patients pay about 14% of drug costs out of pocket. Other categories: nursing home care, dental services, home health, and other professional services together account for about 20% of personal healthcare spending. Home health has grown over 400% since 2000. Administrative costs, both government and private insurance, total 8.7% of spending. Public health, research, and investment in structures round out the picture. Section 5, Why Americans Spend More. The U.S. spending premium. U.S. per capita spending on healthcare is over 50% higher than in most other developed countries. Much of this is predictable. Countries with higher living standards spend more on health. But even within the US, variations are dramatic. In 2009, per capita spending ranged from $5,031 in Utah to $9,278 in Massachusetts. If everyone spent like Utah, total spending would drop 35%. Three important questions. High spending raises three important questions. First, what is a reasonable percentage of output to devote to healthcare? No one knows the ideal number. Second, are we getting our money's worth? Evidence suggests increased spending over 40 years provided substantial benefits that outweigh costs. Third, how much can we afford? These questions matter more than the spending level itself. The value debate. Empirical evidence indicates that increased healthcare spending provides substantial benefits. Lichtenberg's analysis found that medical innovation, especially new drugs, contributed positively to increased longevity between 1960 and 1997. Cutler and McClellan examined 5 common conditions and concluded healthcare spending was worth the cost. The most cost-effective way to increase life expectancy may be through new drug development. Quality and outcomes. Critics cite poor U.S. health outcomes as evidence of system failure. The U.S. does lag in life expectancy and infant mortality, but these are crude measures that ignore underlying demographic and social factors. They say more about environment and lifestyle than medical care. The U.S. system must deal with higher incidence of drug abuse, violence, and other social problems that complicate care delivery. Section 6, The Spending Problem. Reframing the problem, from an economic perspective, there is no optimal level of healthcare spending. High levels are not a problem in themselves. They merely divert attention from more relevant issues: inefficiencies in our delivery system, challenges in financing care, and making it available to everyone who needs it. Rising spending is primarily a political concern. Politicians never pass up an opportunity to fan the flames of any crisis. Why we should care. That said, we should not ignore high spending. David Cutler addressed why we should pay attention. A significant proportion of our spending is wasteful. If we want to be good managers of scarce resources, we should use them more effectively. Wasteful spending includes equivocal treatments, high prices, excessive administrative costs, and outright fraud and abuse. The waste problem: much medical care is worth the cost, but not all of it. A significant proportion of resources are misallocated, providing care that is unnecessary or inappropriate. We often fail to provide the right treatment in the right place at the right time. Too many high priced procedures, not enough primary and preventive care, too much basic care in emergency departments, delayed care because people lack reliable financing. Waste estimates. Schrank and colleagues reviewed 54 studies estimating excess spending across 6 domains. These include failures in care delivery and coordination, overtreatment, low valued care, pricing failures, and fraud. The National Healthcare Anti-Fraud Association estimates about 3% of spending is lost to fraud. Medicare's fraud rate is around 8.5%. Medicaid's improper payment rate may reach 10.5%. The drivers of healthcare costs are complex. They range from life-saving innovations to administrative hurdles. But is this upward trajectory just inefficiency, or is there a deeper economic principle at play? In our final part, we'll explore the famous cost disease of healthcare and discuss the strategic outlook for future administrators. Don't miss the conclusion to Chapter 2,